Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy Cancer Center. I'm also the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic this evening is psychosocial oncology, and our guest is Dr. Linda Carlson. Welcome, Linda. Linda is a clinical psychologist, professor at University of Calgary, and she also holds the chair in psychosocial psychology, and that's the Enbridge Research Chair in psychosocial psychology at the University of Calgary. And Linda and I had the opportunity to meet in person earlier this year when we were both attending an integrative oncology meeting in Seattle. So welcome.
Thank you. Great to be here, Dick, and wonderful to see the program you've got going here. It looks fantastic.
Yeah, so let's get to know you first as a person before we start talking about kind of your professional expertise. So where did you grow up? Are you a Canadian, and did you grow up in Western Canada?
Yeah, I'm a Canadian. I actually was born in England, but my dad was at Oxford at the time as a postdoc. So I was born in Oxford, England, but my parents are third generation Albertans in Canada. So we ended up coming back here after a few years. And so I basically grew up in Calgary, which is at the foothills of the Canadian Rocky Mountains for Americans in the crowd, just north of Montana, we often say. And so I went away and did my master's and PhD in clinical psychology at McGill University in Montreal, but ended up coming back to Calgary and have been at the Cancer Center here for 25 years, since 1998, actually.
Wow. So I'm interested in maybe your background. So your dad's getting a postdoc at Oxford. What was your dad's area of expertise?
Nuclear physics.
Okay. Wow. And then you came back to Canada. How old were you when you moved back to Canada? Were you still an infant, or?
We went to Australia for 3 years after that for another postdoc because he was doing things with particle accelerators, and there were only so many in the world. So there was one in Canberra. So I actually spent the first 3 years of my toddlerhood in Australia, and then came back to Canada when I was 3 or 4, something like that.
And then, high school in the Calgary area or small towns? Okay.
No, in Calgary. Well, Calgary was a smaller town back then, actually. Calgary is about 1.5 million now. But when I was growing up, it was 600,000 or 700,000. So it's really grown immensely over the last 40 years.
So when you started college, what was your first declared major?
Well, I was in sciences to start with in undergrad. So I did undergrad at University of Calgary, stuck around, and was doing biology, chemistry, and I took a few options. And one of them was psychology and sociology and interesting things like that, and realized that I really loved psychology and just understanding human behavior and emotions. And so I actually switched to do a major in psychology after my second year.
And then your graduate work, how did you go from psychology into psychosocial oncology?
Yeah, so I got a just general undergrad, a BSc in psychology, and then the next step is to do graduate studies in clinical psychology. So I chose clinical, which is a broad field, really, where you're just trained to be what people consider a psychologist to be, so someone who can do therapy. And so within clinical psychology, you can specialize in health psychology, or behavioral medicine, it's sometimes called. So this is looking at how our emotions and our behaviors affect our risk for different diseases, but also how we cope with diseases and how we recover. So that's the broad field of health psychology. And people often specialize in specific diseases within that. So in my PhD, my thesis was actually, I've always had an interest in the mind-body connection. So it was looking at hormones. Oops, it disappeared. You're still there though, right?
Yeah, I'm still here. Yep.
So my PhD was looking at, it's called psychoneuroendocrinology. So looking at connections between the psychological factors like mood and memory. And so it's psychoneuro, so the nervous system, and also the endocrine and immune systems, and endocrinology. So that was hormones. So specifically, I was looking at hormones and behavior, and how my PhD thesis was looking at women who were pre and postmenopausal and looking at how their estrogen and their hormone levels affected their cognitive function and their memory and their mood.
Great.
Yeah, so that's this area within health psychology that's sometimes called psychoneuroimmunology, where you're looking at, it's the scientific way that we study the mind-body connection. It's pretty cool.
Yeah. So let me give you a little example, and then I'm going to have you give me a better example. So I kind of think of it, and when I explain to patients, when people think about, oh, this mind-body connection, but let's say, I walk out the back door to take some garbage out, and a dog jumps out of a bush and barks, doesn't touch me in any way. I mean, I feel a body effect of what has just happened. It is quite apparent with my heart rate and my dry mouth and all of that. And that if you're in the room with somebody there's loving kindness, there's similar things that happen, but we don't feel it quite as obviously. But that sort of fight and flight that everybody experiences is really this mind-body connection. So
Sure. I mean,
how
another example of that, yeah, I mean, that's exactly the fight or flight response. So yeah, you may be in an actual dangerous situation where you're driving along and yeah, a dog runs in front of your car. Of course, you're gonna, startle and you feel your heart racing and your palms are sweaty and you're tense. That's the fight or flight reaction. But there's more subtle ways that our thoughts affect our what's happening, in our nervous system, our endocrine system, our immune system, and a really good way to illustrate just that mind-body connection I often do with people is, and we'll just do it just so for a moment, maybe just close your eyes for a moment. So you're not even looking at anything around you. You're just using your imagination. Take a couple of breaths if you want. But imagine, say you're standing in your kitchen and you're standing at a countertop and you've got a chopping board in front of you and there's a lemon on the chopping board. So picture the lemon, it's bright yellow color, it's smooth, shiny surface, little dimples, the bumps on either end. And, you can reach out and pick up the lemon and feel its weight. It's a heavy, juicy lemon. It feels slightly warm. Put it down again and imagine you've got a nice sharp cutting knife. And you take and slice right through the middle of the lemon, right across its largest waste part. And the two sides roll open and little drops of juice are now coming out of the lemon. And you can see the different sections that are separated by the filaments and the juicy little segments. And pick up half of that lemon and bring it to your nose. Breathe in that citrus scent, and perhaps you even want to squeeze a couple of drops onto your tongue or your lips. Okay, and notice what happens to your body when you do that. What do you notice?
I'm feeling it in my parotid glands and I'm salivating.
Yeah, and are there any lemons here?
No lemons. Yeah, that is great. I've never participated in that sort of experiment before. Let's ask, do you guys also sense that? Yeah. Yeah, they're feeling it in their mouth as well. That is
Yeah, for
great.
sure. And that's possible because we all have experience with lemons, or most people do. And so just your mind, your memory, bringing it into mind has that same physical reaction as a real lemon. And so you can extend this metaphor to all kinds of things you could bring to mind that affect your body. And in fact, there is no separation. So every state of mind, every thought, every feeling, every emotion we have is experienced both cognitively, like in thoughts, and emotionally in feelings, and it's experienced in your body as well.
Yeah, I think this idea of consciousness is sort of a big frontier. And I don't think we're going to go down that pathway right now tonight because there's other things, but I would love to explore that as well. So tell us some more about then specifically getting into oncology.
Sure.
And
Yeah.
and did you have an experience like as a clinical psychologist working with cancer patients or caregivers? And
Sure.
was there a personal family experience or
Well, let me
what?
tell you, yeah, I'll tell you the next step. So I did my PhD in psychoneuroendocrinology, trained as a clinical health psychologist generally. And the last piece of our training is we do a 1-year internship or a fellowship or residency, the sort of parallel to a medical residency. And so I ended up coming back to Calgary and did part of my residency at the Cancer Center. So that's when I first encountered working with people who have cancer and their family members. and really just resonated with that group of people and their experience, and recognized that the sorts of practices I'd been learning. So at the same time as I was doing my PhD, I had started meditating. I actually had a classmate who was a monk who had spent 7 years in the forest studying meditation in Thailand, right, before he came back to grad school. And so he taught a group of us meditation. And so I had been doing that throughout my PhD and been practicing yoga, came to the cancer center, met some colleagues who had similar interests, and we could see that the people going through cancer really were struggling in so many ways that may benefit from the practices of the meditation and the yoga, both mentally and physically. And nobody had really done that in this space yet. So this was back in 1998. There was a program called mindfulness-based stress reduction that was becoming popular from Jon Kabat-Zinn in the States, but it had never been adapted for people with cancer and their very specific challenges. And so we did that. We created a program called Mindfulness-Based Cancer Recovery, and started offering it to people at our cancer center. And so from that point on, I was actually kind of hooked, seeing just how receptive. So it's kind of a double-edged sword. No one wants cancer, obviously. It's an incredibly difficult experience, but at the same time, it kind of primes people to stop for a moment and maybe reflect on how they're living their lives, and how they want to live their lives going forward. So it's almost like a catalyst or a turning point for many people. And so people were very motivated to explore these things and learn how they might apply to coping with the uncertainties of cancer, the feeling of loss of control, the fear of recurrence that is always a part of that. And so we continued to develop this program and conduct research on its effects, both psychological and in the body, and physical effects on different side effects and symptoms. And so that's how I got into this sort of area of what we now call integrative oncology.
And can you maybe summarize the results of using mindfulness-based stress reduction techniques with cancer patients? What did you find?
Sure. I mean, we've had a 25-year research program in this area, but we started just by giving people questionnaires about stress and mood before the program and after the program. And we had comparison groups who didn't do the program to compare with. And so we saw really large effects on things like overall mood, less anxiety, less anger, less depression, less confusion, more energy, fewer stress symptoms, so less tension in the body, fewer problems with like insomnia, not sleeping well, discomfort. And so that was from people's own self-report. And so we just continued on that line of research, and we started doing things like taking blood samples and saliva samples and looking at blood pressure, and have looked at things like immune function and stress hormone levels. And we've even gone right into the level of the cellular DNA and looked at telomere length, which is a marker of cell aging. And all these things are impacted by our program, which is like 8 weeks of intensive daily practice of meditation and mindful movement, and learning some of the concepts around mindfulness, which is about, just so mindful, I'll give you a definition. So mindfulness is just paying attention in the present moment with a kind and accepting sort of attitude. So all the practices we do, the meditation, the yoga, it's all ways to cultivate this idea of mindfulness, this concept of mindfulness. And so we've been able to quantify the effects, across many different outcomes. We've looked at those kind of problems people have, like difficulty sleeping, symptoms of pain and fatigue, and many of these things improve for many people when they do these programs.
Right. And the classic mindfulness-based stress reduction program, as you mentioned, is an 8-week program.
Mm-hmm.
And obviously that's the way it was set up by Jon Kabat-Zinn. And so many of the research studies kind of look at that traditional length of time.
Yeah.
I find that many of my patients aren't able to commit to that length of time. Have you done any research on using the techniques of mindfulness-based stress reduction, but in smaller segments over maybe shorter periods of time? And has anyone been able to demonstrate similar positive findings with a less intense regimen?
There's not a ton of research within oncology on shortened versions. One study we did was that we assessed people at the beginning and then in the middle, like after 4 weeks, to see how they're doing, and then after 8 weeks again. And there were definitely benefits from 4 weeks of practice. Like, we were seeing improvements, but they weren't as large as you saw after the full 8-week practice. Other studies in other populations of people have certainly done shorter versions and still shown some benefit. And, I'm not sure if it's a linear kind of dose response. The more you do, the more you improve. But I think there is a minimal amount of learning and practice that a person has to engage with to really have the personal lived experience of what this is all about, because it's learning a skill, right? And that's the way we think about it, is that, if you want to play tennis or be a concert pianist, you've got to practice your scales. You've got to do the serves. You have to put in the time to train your mind and your body in that new skill. And being more mindful day to day doesn't happen necessarily just because we think it's a good idea. We have to train ourselves through this regular practice. So I do believe that people have to commit a certain amount of time and effort to realize the full benefits of this. But at the same time, something is better than nothing, right?
Yeah. And intuitively, I would think that, if you want to derive really long-term benefits that lasts over years or a decade, you probably need to have a practice that continues beyond the 8 weeks, or it would
Well,
seem.
so we have followed people up who go through our program over 6 months, a year. And interestingly, we do find some benefits are persistent, even if people aren't practicing regularly anymore. So there's some things that are just a shift in the way you think about the world or the way you interpret things that are happening to you. The stories you tell yourself about the meaning of things in the world shifts. And so that doesn't change whether you're practicing or not, but the capacity to, the regular practice just lowers kind of your set point. When you talk about that fight or flight, sometimes we're just going through life just vibrating at a very high level. It's uncomfortable and it doesn't take much to set you off, so you're crying or you're snapping at someone or you're kind of losing it, right? So the regular practice just lowers that set point so that you're more resilient, right? You have the capacity to handle life's up and downs without so much instability and, feeling rotten all the time, right?
Let's transition from mindfulness as a practice that clearly has benefit, and then I'd love to have you describe integrative oncology and maybe tell us your own your professional transition from where you started with your PhD program and your year of residency, and how that has broadened into what we call integrative oncology.
Sure. So I guess we can think of the larger field of psychosocial oncology. So that's really just everything to do with how our thoughts, our feelings, our emotions, our relationships impact how a person copes with a cancer experience. Within that, integrative oncology is sort of a subset of the different kind of interventions we might offer. And so integrative oncology, one important part of the definition is that it's integrating complementary therapies with conventional therapies. So it's evidence-based, it's integrated with conventional care. And the types of therapies we're talking about are things like the mind-body therapies. So I mentioned mindfulness, but also things like yoga, Tai Chi, Qigong, relaxation, imagery, hypnosis. Those are all mind-body therapies. Things like acupuncture has a strong evidence base for helping with pain, for example. So there's the mind-body therapies. There's also the lifestyle therapies, we might call them. So exercise and nutrition fall under the umbrella of integrative oncology, as well as natural health products. So different vitamins, herbs, sort of special diets people might follow. So the natural health products, those are all under the integrative oncology umbrella. So the idea is to take the best evidence-based interventions, integrate them with conventional care, and just improve the overall quality of life and outcomes for people going through cancer. Yeah, sort
Right.
of.
And a lot of the things that you described are beneficial for someone even if they don't have a
Oh,
diagnosis.
absolutely.
Yeah.
Yeah.
But we call it integrative oncology because you and I work in cancer centers. And yes, we care about the whole world, but our patients are cancer patients. So we're bringing it into the cancer center.
That's right. So we're integrating these therapies that exactly can benefit many people in many different ways, but specifically looking at how do they work in the context of treatment, diagnosis, recovery from cancer, and how can we combine them with the conventional treatments people are getting.
And I know when we met, you described this very beautiful new physical building and that you have in the University of Calgary at the Cancer Center. Maybe describe how you either gradually or quickly brought into the Cancer Center with the oncologists that are focusing on surgery and chemotherapy and radiation therapy. How did you bring an integrative oncology program into the Cancer Center at the University of Calgary?
Sure, sure. So I would say we did it gradually. I guess the beauty of our system in Canada is that it's a publicly funded healthcare system. So we have one cancer provider in our whole province. It's called Cancer Care Alberta. And so all the services provided to cancer patients are through that one provider. And within Cancer Care Alberta, we already had a very strong psychosocial oncology division or department. And so we already had on the payroll, on staff, clinical social workers, psychologists, psychiatrists who were already there. And so we were able to train those people in a lot of the mind-body therapies. So that's where we began with the mind-body therapies, because psychologists, social workers are already trained often in those therapies and are qualified to learn how to deliver them. So we just started training people who were already in the system on the different mind-body therapies, and then they could offer them to their clients as appropriate. And so there wasn't really any, sort of big investment that anyone had to say, oh, our stamp of approval on integrative oncology. So we started there. And then I also began expanding integrative oncology as an actual program, a good 15, well, maybe 2012. So we're talking about 13 years ago now. It became an official program of integrative oncology. And so we began things like education programs. So education for healthcare providers, education for patients around what are integrative therapies, which ones have promise, which ones have evidence for their efficacy. Because, we know the stats are that at least 50% of people with cancer have used some form of complementary therapy since their diagnosis. And so much of this was happening without any professional guidance, because there wasn't a lot of knowledge among the oncologists, the nurses. People would come and say, hey, should I do this? Should I try that? What do you think of this? And they'd be like, oh, I don't know.
Right, right. And so maybe I'm interested in your thoughts because I know you're not only a clinical psychologist, but you're a scientist, and that you strong believer in evidence-based and not just other people's evidence, but you're creating the evidence at the University of Calgary. Which of the mind body integrative oncology practices, and let's not limit it to the mind body, let's include the
Sure.
physical, the diet, exercise, all of that. Which ones do you think have the evidence that they are the most useful in what situations,
Sure.
and which practices we might all do that probably don't have the strong evidence on benefiting patients?
Sure. So let's start with the evidence-based recommended therapy. So I'm part of an organization called the Society for Integrative Oncology. I'm actually the past president there, but it's an international society of lots of interdisciplinary professionals from around the world who do research and practice in integrative oncology. And so SIO partnered with ASCO, that's the American Society of Clinical Oncology. So the largest professional organization of oncologists in the world, 60,000 of them. We partnered together to review all the evidence of integrative therapies within cancer for certain symptom management areas. And we produce guidelines that are publicly available, that are on the ASCO website. And so the first one that came out was for pain, and that was in 2022. And so the bar to be included in the recommendations was very high. It was only looking at high quality randomized controlled trials that were quite large. And so the most highly recommended integrative therapies for pain is acupuncture. And in the guideline, we break pain down into different types of pain. So there's general pain, but there's also pain caused by some of the aromatase inhibitors or the drugs that women with breast cancer have to take long term, and they can cause pain, for example, or swelling in the joints. And so acupuncture and yoga are the most highly recommended therapies for those different pain syndromes. But we also see things like massage in palliative care is recommended, or even reflexology or reflexology massage is in the recommendations. So we see those things for pain. Then the next guideline we did was for anxiety and depression. And what came out on top there was mindfulness-based interventions like we were just talking about. So those are the most strongly recommended or have the most evidence to support them. But we also see things like Tai Chi and Qigong. Again, we see yoga-based interventions, we see relaxation therapies, and that's a low-hanging fruit. You can easily get guided relaxations on the internet, and you can also get guided meditations. Imagery can be helpful for anxiety reduction. There's some other ones that came out. Those are kind of the main ones.
Okay. So we recently brought into our program certified licensed music therapy and art
so music therapy is in the guideline as well. Yeah. So when we look at creative therapies, the one that has the most evidence would be the music therapy. So that is in the anxiety recommendation and also shows up in the pain recommendation, less sort of highly supported with the evidence. And the third guideline, if I can do you want to just briefly review that?
Yes, please.
Is for fatigue. And fatigue is the most common, long-term lingering problem that people have. And the most highly recommended intervention there is exercise or physical activity. So we see that as one of the most beneficial things people can do for fatigue. And also things like mindfulness-based interventions or counseling, cognitive behavior therapy comes up there.
So back to the creative therapies, if you will, and I would probably put in there, music therapy, art therapy, perhaps journaling.
Yeah, journaling, movement to music.
So those can also be part of just a positive psychology program. I mean, I think you don't have to have a certified DSM diagnosis of something to get benefit out of some of these creative. And so with my patients, I often will say, there's evidence that this might help with depression, anxiety, PTSD, but you don't have to have anxiety, depression, PTSD to get benefit out of participating in some of these creative mind-body endeavors.
You know what those things are really great for? Because they're nonverbal. You don't have to talk about your emotions. They're just really good for expressing and processing difficult emotions, right? So you might not be able to describe how you're feeling, but maybe you can draw it. Right? Maybe you can paint it. Maybe you can, make music that captures it or move to music. And it's just such a great way to express everything that's built up and really very freeing. And it's a great coping mechanism. And there is evidence for these creative therapies, maybe more so in other groups than cancer, but it's beginning to accumulate, for people with cancer as well.
So in our center, from a brochure perspective, we tend to lump things as touch therapies, where someone is going to actually touch you. And we include in that acupuncture, chiropractic care, massage therapy, reflexology, Reiki, physical therapy, osteopathic manipulation. And maybe let's start with those. Any of the ones that I mentioned, some of those are sounding pretty conventional, like physical therapy, and
Yeah, for sure.
others are not so conventional, perhaps like Reiki. Um, uh, are you doing research on
Yeah.
all of
So
those? And
for sure. So there's not enough research on Reiki or therapeutic touch to make the guidelines, but actually my group even did a study on Reiki a long time ago. Like we published it in 2007, I think. But we had a number of people experience 5 days of Reiki with a trained, Reiki practitioner, compared to 5 days of just resting. So they either did the Reiki first, and then before and after each session, they rated their tiredness. So we were looking at fatigue. And then the same thing, they rested for the same amount of time and they rated their fatigue before and after. And then after they tried both things, we followed them up. And so what happened was that the people who had the Reiki, their fatigue, it would decrease after each session, it would go up a little, but then it would go down after the next session, up a little. So after 5 or 7 sessions, which was the total, their fatigue had gone down quite a bit. And we didn't see that same pattern with just resting. So that's an example of one study that's been done in Reiki. And there's, a number of others. Again, there's just not enough of those high quality, large randomized controlled trials that are necessary to get into the guideline, but it certainly is promising.
so, as a scientist and past president of the Society for Integrative Oncology, so on my treating of cancer patients, I work with the National Cancer Institute, and I've got 70 clinical trials that are open. Some of them are treatment, some are symptom management. Is there such a thing as a cooperative group where centers like mine could participate in the research, where we share then the number of patients to try to get results more quickly by pooling patients from a number of centers?
Sure. There's a couple of things like that going on. Like, so through it's called NCCIH, the National Center for Complementary and Integrative Health. So that's a center of NIH. They fund some of these collaborative grants. Like, for example, they have one funded right now for music therapy. And so it's got, I think, 4 different sites around the country that are participating in these music therapy studies to get larger sample sizes. So that's one example. Another one that you and I have talked about is the BraveNet Collaborative. And this is a large group. I don't know how many now, 80 maybe, different sites all across the states and, a couple in different countries. And it's practice-based research. So it's any sort of site, or it can be like a big hospital or even a community hospital. And it's not just in oncology, it's across all different conditions, but they offer integrative therapies like massage or Reiki or acupuncture. And they can collect similar kinds of data from their patients, using the same kind of measures, say on pain, right? And then you can bring together maybe 10 people from here, 100 people from there, 1,000 people from there, and they've all got the same kind of measures. So you can see overall in the real world, what's the impact of these kind of practices on, say, pain, right? So that's like a practice-based research network. So that's really a great way to use the power of many different sites to increase the sample size.
Which of the integrative oncology practices are you most excited about, and which ones are you bringing into your cancer center there at the University of Calgary?
Well, so I'm trying to follow the guidelines and get everything that's recommended in the guidelines that we don't already have. And there are definite holes here, just because I haven't been able to get permission or get people trained or have the space or have the funding. So we have a lot of the mind-body therapies. I actually just got approval for our physiatrists to do acupuncture. So they'll be able to offer that as a clinical service. I'm like super excited about that. And we also do research studies in these areas too for therapies that maybe aren't in the guidelines yet. So the other guideline-based therapies we're working on is music therapy, like you've mentioned, and also I'd like to get some massage.
Okay. One area that
And actually, we're also doing some biofield work as well. So like Reiki and other types of biofield therapies.
Okay.
Oh, and I just got a huge grant, and this is a whole other topic, but so it's called the Canadian Network for Psychedelic Assisted Cancer Therapy. So we're looking at different psychedelics in conjunction with therapy for helping people to cope with the more existential anxiety closer to end of life.
Yeah, let's talk about psychedelics for a bit. So, obviously, a lot of people are writing about it. There's lots of articles in the lay press and lots of pluses and minuses. I mean, historically, it kind of got off to a bad start when the people doing the studies were also the participants. And I think back to Timothy O'Leary and some of the stuff back then. Where do we stand right now with
Yeah.
the current evidence-based indications for psychedelics? Which ones are being used? I mean, does
Mhm.
ketamine fall into that category or
Okay. Well,
not?
do we want to talk just in cancer or more generally?
I'll let you talk in general, and then we'll we'll
Sure.
we'll get
Yeah.
down to specifically cancer.
Yeah, so historically, there was some promising research happening back in the 50s and 60s, even within cancer, with agents like LSD and showing some promise for maybe treating some of these psychosocial symptoms. But then it was all shut down in the Nixon era for a couple of decades. So it's really only in the last 15, 20 years that people have come back to this idea that maybe as a medicine, as a therapy, that these different psychedelics might be able to treat certain difficult to treat, psychiatric conditions. So one of the ones that's been most studied is depression or treatment-resistant depression specifically. And people have looked at psilocybin from magic mushrooms in that context. Another area that's been studied a lot is trauma or post-traumatic stress disorder. So looking at veterans or looking at other trauma survivors. And in that context, people have mostly been studying MDMA or ecstasy. And so that seems to be quite effective in many cases for alleviating post-traumatic stress. So there's MDMA for post-traumatic stress. There's psilocybin for treatment-resistant depression. The ketamine situation is that ketamine can also help with depression largely. And it's been used a lot because it's not regulated so much, it's legal, right? So there's been a lot of ketamine clinics springing up. I think the research shows that with the ketamine, it's not as long lasting and you maybe have to have continued doses and maybe not quite as profound an impact as something that creates a mystical experience. So within cancer, there's two clinical trials from 2016 in the United States that looked at psilocybin, so high doses of the magic mushroom component psilocybin for people with advanced cancer who were suffering from anxiety, depression, existential anxiety. And so what these studies showed is that one or two high doses that induce a psychedelic experience and perhaps a mystical experience where people feel, really connected to the universe, and it can have the impact of just completely alleviating people's anxiety or fear of dying, and last for a long time too. And these were very small clinical trials, mind you, but really promising because that's a very difficult thing to manage at end of life. It causes a lot of distress for healthcare providers, for patients, for family members. And so that's kind of where we're at now. And you're right, there's a ton of hype. There's lots of stories. It's in the media. It's kind of gotten, I think, a little bit overblown, like beyond what the evidence tells us, but it just shows you that people are clamoring for something like this. And so our team was just funded, and we're all across Canada, and we're just kind of going back to the drawing board and talking to patients and healthcare providers and policymakers about, where do they want to see this go? What's their interest? How would they like to see it unfolding within cancer care? And then we'll be conducting some clinical trials.
And do you have a vision for which substances you want to look at? I would imagine, as you mentioned, because ketamine is used in the world of anesthesia, it's a legal drug, it's used in situations. So kind of using it for depression or for something else is not that tough. It's off-label, but it's not illegal.
Mm-hmm.
Are you using ketamine at all for any cancer-related depression or existential issues at end of life?
It's not really happening in the cancer centers.
Okay.
So I think there's some private clinics that are offering that sort of service. But within the publicly funded cancer centers, we're not seeing any psychedelic assisted therapy at all, really, except maybe the odd small clinical trial. The most interest, so we've already done a survey of over 700 people with about 500 patients and 150 healthcare providers. They're mostly enthusiastic about psilocybin.
Okay.
Yeah, so likely that's where our clinical trials will fall.
Okay. And another area is just supplements in general.
Mm.
And those would be, anything from nutritional supplements to more those supplements that are marketed for not necessarily for quality of life, but are marketed specifically to help reduce the burden of cancer by treating the cancer or preventing cancer. And uh, how do you look at that as a scientist? How do you look at that in your cancer center? How do you approach patients who come in for, conventional treatment, chemo, radiation, and surgery, but are also, ordering turkey tail mushrooms and ivermectin or a number of other things off the internet?
It's a tough one, right? So in our clinical practice guidelines, we not only looked at the mind-body therapies, we also looked at all the supplements and all the research on the supplements. But there just wasn't enough high quality research to include really any of them in the recommendations and the guidelines. It doesn't mean that they don't have potential or could have benefit, but there's just not been enough research conducted to really know. Of course, as an oncologist that there's concern about potential drug-drug interactions, and conventional medical professionals are pretty conservative, right? So a lot of the advice that our patients are getting is just don't take any of that stuff. And I think in many cases that probably is overly conservative. There are certainly huge benefits from, for example, antioxidant rich foods. For many different, like, for example, there's lots of research showing that people who eat foods that are high in vitamin C and vitamin A and get lots of antioxidants have decreased risk for developing certain types of cancers, right? But there's not enough research to generalize into whether those could be things that are going to improve treatment outcome. And again, there's these potential risks. So there are some very good tools that healthcare providers can use that look specifically at the evidence for drug-drug interactions. And in some cases, there's actually synergies where certain, supplements, like it's usually antioxidant vitamins or things like that, melatonin or whatever, might actually enhance the impact of certain conventional cancer therapies. So, for example, I don't know if you've used the one called Efficasafe.
Say that again.
It's called Efficasafe. So like efficacy,
okay.
safe. It's actually really, really good. And yeah,
it's a tool, a website, or
yeah.
Yes. Okay.
Yeah,
Gotcha.
You can try it for free, but you just put in everything. Like if a person's on a certain type of chemotherapy, you put it in. If they want to take a certain supplement, you put it in, and it might say contraindicated, don't do this. Or it might say, yeah, this is okay in this case. So it's more nuanced than that kind of blanket advice. Yeah. And the other thing I would recommend just for people who are listening is the About Herbs app. Are you familiar with that one? It's called About Herbs. Yeah. So Memorial Sloan Kettering Cancer Center produces this. It's a website and it's an app, and it's free, public facing. So you can put in there any supplement you want or any symptom you want, like hot flashes, and it'll tell you all the things you might use, and it reviews the evidence and it tells you contraindications. Oh, so that's really useful.
That is great. So the solution that we have done is we have a university with a pharmacy school here, and we have one of the pharmacologists who meets with our patients in our clinic. So they're not involved in the cancer care of the patient, and they just approach everything from the scientific point of view, and patients can talk about any supplement they want. And the pharmacologist will know what their regimen is and also what their prescriptions are, but the patients tend to be more open with sharing all of the things they're doing and getting a better feel for interactions, but also leading them in a conversation about what might be over-the-counter remedies for managing either symptoms they're having or side effects of treatment. So, but these two websites that you mentioned, that's a great resource. So we'll incorporate that into our patient information.
It's a tough one, right? Because, you want to maintain a good rapport and a good patient-provider relationship. So if the provider is just saying, nope, don't want to hear about it, I mean, the patients are just going to go off and do it anyway without their advice, and it impacts that rapport. So having the pharmacist there that people can talk openly, to someone who's educated. Because when we surveyed people, where do you get information to make decisions about these natural health products and supplements? They're like, oh, the internet, friends, family, like wherever,
Right.
so who knows? And these things can be very costly, right? So you don't want to be wasting your hard-earned money on things that aren't likely to have benefit. So I always say to people, start with the recommendations. Like if it's pain, depending on what you're trying to treat, there may be good evidence-based therapies that you can turn to first.
Right. And sort of my scientific skepticism is also who is making how much money off of these.
Absolutely.
And,
And educating people on how to read websites, right? Like whose website is it? Is it the manufacturer who's trying to market this product and all these great testimonials? Well, you can't trust that kind of stuff, so being able to go to trusted sources like American Cancer Society and Memorial Sloan Kettering and that kind of thing, right?
So, Linda, before we open it up to questions, any aspect of integrative oncology in the real world that we live in right now that you would like to highlight before we ask our audience for questions?
I think we've covered a lot already. Why don't we just open it up?
That's great. So we'll start with our live studio audience. And then if you are watching us live streaming right now, please put your question in the comment section of the software that you're using to watch us this evening. And we'll start with Poon.
Linda, does your pharmacologist look at the psychedelics compare with the drugs the cancer patients are using to determine if those are safe?
Yeah, so we're not actually administering the psychedelics quite yet, but when we do, we'll be very careful to make sure that there's no potential for adverse effects or interactions, for sure.
So, Linda, you're not doing the studies yet. When I've watched some documentaries, and I know that some of these, you've got to be observing the patient. Someone's in the room. Someone is sort of helping them on their journey.
Yeah.
It can be
I can
quite
explain
complicated.
It is. So it's called psychedelic assisted therapy. And so, for example, with the psilocybin, before you even give them the drug, there's preparation sessions, like 2 or 3 preparation sessions, just to get ready to prepare for what is likely to happen, what that experience will be, a bit of supportive psychotherapy. And then the dosing session, it takes 8 hours, it lasts for quite a while, and they're in a safe, comfortable environment. There's 1 or 2 people with them the entire time, just monitoring them, making sure they're safe, supporting them if they need it. And then there's integration sessions afterwards, 2 or 3 of those, where whatever came up during the session is discussed and integrated into the general therapy. Yeah.
Next. Yes, George.
I'm curious as to what the leadership role was of Canada in research prior to the recent news. And is that changing at all? There's a lot of fright down here, and maybe justifiably so, about research being cut back, about funding being cut back. You've mentioned several times that you've just been funded. You've just gotten funding up there. Do you see your leadership role changing at all when it comes to research and development of cancer treatments?
Yeah, that's interesting. So we haven't had any negative impact up here in Canada in terms of our funding or our leadership. There's still support for the same level, if not increase. We just had an election. We have a new government in that's very supportive around research and healthcare. So we've always been leaders in certain areas. I think it's very sad, and especially because I know many people personally who have lost their funding for very important research. And so I think you're right. There's going to be a gap for a while until maybe things change, things catch up, where other countries are probably going to be turned to more for, providing the evidence and moving the field forward. So we're actually quite pleased in Canada to have this opportunity within the psychedelic space, but we'd rather have everybody moving along with us for sure. Right?
Yeah. Have you had an increased number of calls by researchers south of your border interested in opportunities north of our border?
Definitely. Same thing happened in 2016. Yeah.
Okay.
Yeah, it's not that easy to move to Canada. I mean, there are certain job opportunities, but there are some provinces that are specifically trying to recruit now scientists and doctors from the States and making it a bit easier. So I think it is an opportunity in many ways to build up our, we call it the brain drain, so the reverse brain drain, I guess.
Yes. Ron.
Kind of a quick comment. What you're doing up there sounds fascinating. Really applaud you for all your efforts in that. And on the notion of psychedelics, you mentioned that, getting a broader view of the universe, so to speak, that somehow is embellishing people's faith in something larger than what we see. And I'm not sure how to ask a question on that. Is that?
Do you want me to just elaborate on that a bit? Or?
Yeah, please elaborate on this.
Yeah,
you used the term a couple times, mystical, and that's coming from drugs. And maybe as you elaborate, are there other ways of having mystical experiences?
So because in the mindfulness field, many people who meditate have this same experience of expansion, of boundlessness, it's a dissolving of the distinction or the ego boundary, we might call it, or it's called self-transcendence or non-dual awareness. So it almost seems like some of these psychedelics are like, accelerated pathway into that place of self-transcendence or non-dual awareness. And what's characteristic of that state is just a profound feeling of peace and calm and like nothing really to be afraid of. Like there's feeling really connected with the rest of the universe or, with a spiritual connection. So for many people, depending on your spiritual background or your religious background, you might feel a connection with God or with the universe or with some deity. But it's this feeling of transcending the self and being connected with something larger than the self that often lends this feeling of peacefulness and calm. And so people come out of that experience and they keep with them that lack of worry about dying. All of a sudden they're like, it's going to be fine. So it's really quite interesting to talk to people who've been through that. Yeah.
I like the way that you say it's sort of perhaps a faster or shortcut way of getting to something that could be done in other ways. I just, as you're describing this, I think of the experience I sometimes have at the top of a mountain that I've been climbing, and I often describe it as this sense of being just a speck in a universe that is huge, but yet feeling special in a way, in this combination of being even special and insignificant at the same time.
Just one part of a larger whole, right?
Yeah, and
like
that's
part of the net. There's a metaphor called Indra's net, where you're just one node in the net of the entire universe, But it's like exactly like you said, it's you're tiny, but you're also huge. You're everything and nothing. Yeah.
Other questions? Yes.
Yes. Hi, Linda. How you doing tonight? Good.
Good, thanks.
Well, we covered a lot of ground tonight, and one of the things that are going through my mind is, what do you think about things coming down the road within 5 years and within 10 years? What are you most excited about?
So what sorts of things? You mean within integrative oncology?
You betcha.
I'm excited about seeing a lot of these therapies more available to people more broadly, no matter where you live, and not having to pay an arm and a leg for them. So, it's maybe a little boring, but I'd like to see this stuff covered by insurance. I'd like to see everybody who goes through cancer care getting a plan, an individual treatment plan that includes, okay, you'll do your exercise here and you'll get your massage there, and then you'll do your acupuncture and go to your music therapy, right? That's what I'd like to see.
Yeah, I share that. We're working toward it right now. Almost all of ours is provided by philanthropy, not by insurance, and And we are, as we're wrapping up here, we're going to go upstairs, and we've got probably about 25 folks that are going to show up for physical activity. And again, that's all provided by philanthropy as well. But yeah, to be able to incorporate these services that can be very important in improving the health and wellness and outcome in terms of cancer for our patients.
Well, if they'd smarten up the insurance companies, they'd realize that doing all this in the long run is going to save them money, and improve health, because there'll be less requirement for intensive health care when people are doing all these things.
Yes. And evidence like you're helping to accumulate is what's necessary to then convince the insurance companies to cover these services. So thank you so much. Our guest tonight has been Linda Carlson, a clinical psychologist and the head of Psycho-Oncology and Integrative Oncology at the University of Calgary. Thanks for being our guest.
Yeah, it's been really a lot of fun. Thank you for listening.
If those of you watching this evening know someone that would benefit by watching this program, it will be available on demand at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.